This week on the BackTable podcast.
I think the standard labs with EV, CBC, complete blood count, comprehensive metabolic panel, that includes the glucose. I always recommend the patient to follow closely with the primary care. We check hemoglobin A1C, either ourselves or with a PCP to make sure we have a very tight control of diabetes. If we look at the Enfortumab Vedotin trials, patients with uncontrolled diabetes were excluded. So that's kind of a special patient population. People may still give Enfortumab, but takes caution. And again, collaboration with primary care or endocrinologists for diabetic patients. But hyperglycemia can happen again in diabetics and non-diabetics. I think in the context of combination, Pembro plus Enfortumab, we also check, thyroid labs like TSH and 34 and cortisol in the context of Pembro because of the potential of immune-related adverse events. And I think, again, education of the patient and the team and close monitoring are key factors for optimal management and monitoring of those patients.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor. From concept to completion, there's a lot to consider when building a Theranostics or PSMA PET-CT imaging program. It's nearly impossible to be an expert in every aspect of this care pathway, but the success of your program depends on it. Get the support you need from an experienced team. Open your web browser and search Siemens Healthineers Theranostics. You'll see the complete Theranostics care pathway and how they can help you customize it to meet the needs of your prostate cancer patients. Visit their website or stop by Siemens Healthineers booth at the local and national American Urological Association and large urology group practice association meetings. You deliver the care, they'll deliver the rest. Now, back to the show.
My name is Bogdana Schmidt. I'm a urologic oncologist at the University of Utah, and I am thrilled to have with me today Dr. Petros Grivas, Professor of Urologic Oncology and the Clinical Director of GU Cancers Program at the University of Washington and Fred Hutch, and of course, the President of the Monty Pal Fan Club, and also Monty Pal, Professor of Urologic Oncology at City of Hope, and similarly, the president of the Petros Grivas fan club. We've got a phenomenal lineup for you today, talking about the highlights from the most recent ASCO meeting. It was a fantastic meeting. We've got a lot to talk about. Let's jump in and start talking about the abstracts that were interesting and inspiring to you, presented in the bladder cancers. Dr. Grivas, thank you so much.
Thank you so much, Bogdana, for having us. Such a great pleasure to see you and Monty today. And we're energized coming back from ASCO 2024. There's so much to talk about, of course, and I would encourage the audience to go ahead and review comprehensively the ASCO agenda. There's so much to review, but we can today, for the purpose of this discussion, we can focus on a few examples of highlights from the meeting. And I think it's reasonable to discuss a little bit about the frontline setting of advanced metastatic urothelial carcinoma. I can share with you, I was interested to see the quality of life patient report outcomes data from the Pembrolizumab Enfortumab trial.
Perfect. So we've all been super excited and thrilled to hear the EV-Pembro data for the overall survival benefit that it offers. It's certainly the new standard of care for our patients, and we're all thrilled to offer it for the survival benefits, but it was great to see the patient-reported outcomes data that Dr. Gupta presented.
Absolutely. And I think to your point, Bogdana, quality of life and patient-reported outcomes are very important metrics. And I think when we talk to our patients in clinic, they ask us this question, how soon it will take for my pain to get better? How about my function? I will be able or not to attend my granddaughter's graduation, things like that. So I think are important. So in that context, very briefly, I can just update the audience here with the EV302 trial. As you pointed out, Pembrolizumab plus Enfortumab compared to platinum-based chemotherapy, Gemcis or Gemcarbo. The data were presented at ESMO 2023 and subsequently published in New England Journal of Medicine as of March 2024 by Tom Powles and colleagues. And this data showed a significant, I would say impressive, dramatic overall survival and progression-free survival benefit with Pembro and Enfortumab compared to platinum-based chemotherapy. And Dr. Gupta showed patient-reported outcomes data, quality of life data from that trial, looking at different metrics, again, pain, quality of life, global health status, and using different measures, instrument tools. And I will just focus on the conclusions just for the take-home message for the audience. I would say that patients were treated with Pembrolizumab and Enfortumab had significantly improved, of course, survival, as we discussed, without detriment in their global health status or quality of life, pain or functioning. So the survival benefit came out without any negative impact on quality of life. If anything, patients with moderate or severe pain who were treated with Pembro and Enfortumab had a clinically meaningful improvement in worse pain and the quality of life, mainly because Pembro EV had high response rate. Overall response rate was 68%. So if you reduce cancer burden, you may reduce cancer-related symptoms, and also you delayed progression of free survival. So longer time to progression, longer time to cancer-related symptom worsening. So that was, I think, a very positive aspect of the data. And the data collection across the entire patient journey was a significant approach and was associated with difference in compliance between the treatment arms. Of course, it's inherently more difficult to collect quality of life data if someone is not on active treatment and is only on follow-up phase. But overall, the PRO data, I think overall, support the use of Pembro and Enfortumab as one of the preferred standard treatment options in the frontline setting in advanced urothelial carcinoma.
And of course, I know we're a podcast, but I would just encourage our listenership to look at these graphs, because if you look at the original ESMO or the New England Journal paper graphs of EV and Pembro, you don't need an explanation. You see curve separation, and it's obvious and it's wonderful, and it's always the best metric of the data and how strong it is when we don't have to explain anything, when the visual representation is so clear. And I agree with you. I think that for the PRO data, there is a table, a chart really, that looks at all the functional domains, role functioning, physical functioning, social functioning, global health status, quality of life, like you mentioned, cognitive and emotional functioning. And every single one of those metrics favors EV Pembro. So when you see a representation visually that is so clear, I think that represents such great progress for our patients, where we're not having to compromise one domain for another. We are seeing a benefit in every measured aspect of function in our patients. So I agree with you. I think this is fantastic progress.
I agree. And it's really exciting, Bogdana, to see the progress made in the field and the transformative nature of the data with the doubling of the median PFS and median OS. And I think it's a partnership, of course, with our colleagues and friends in urologic oncology. We now have ongoing perioperative trials with Pembrolizumab plus Enfortumab. For example, Keynote 905 in cisplatin-ineligible patients and Keynote B15 in cisplatin-eligible patients. Those two trials are phase 3 randomized studies in a perioperative, localized muscle-invasive bladder cancer setting. So we stay tuned to see what this data show, and potentially, if those trials are positive, we may see Pembro EV moving in the earlier disease states in the localized setting. We'll have to see.
I agree.
I would also add to that, in the context of EV Pembro and the quality of life data, I think this sort of sets an important standard for us too. I think one of the unanswered questions is whether or not we can potentially pause therapy with EV Pembro after a period of time, use it intermittently and so forth. The quality of life data that we see, I think, therefore sets a benchmark for us. So if I were designing a future trial in this space, I might use the same PRO metrics to see if we can improve upon EV Pembro by maybe dosing it in a more intermittent fashion.
Actually, that's the perfect segue, because I was going to say that EV Pembro, even at ESMO, overshadowed the data for using chemotherapy with nivolumab in every way. But there was a really fantastic subset presentation of Checkmate 901 by Dr. Galsky that commented on including a metric of a treatment-free interval. In other words, we know these drugs work. Great PROs demonstrate for EV Pembro that we have good tolerability profile, but every single one of our patients would want to be off therapy for as long as possible, as many times as possible, preferably forever, obviously. But for those of them we can't offer complete cure and they're going to be on treatment, we want to be able to take them on and off treatment. And so I wondered if you could touch on the presentation of that subset. So looking at cisplatin chemotherapy with the addition of nivolumab in the lymph node positive, only lymph node bladder cancer patients. What did you think about that, Dr. Grivas?
Great discussion, and Bogdana, and I agree with you. It's so amazing to see two practice-changing trials in the presidential symposium together, right, at ESMO 2023. And I agree with you, it was hard, for Dr. van der Heijden to give the CheckMate 901 presentation right after the EV302 data from Dr. Powell. So he did a great job, of course. So just very quickly for the audience, frontline setting of advanced urothelial carcinoma, we talked about the EV302 trial. Pembro EV definitely was significantly and dramatically superior to platinum-based chemotherapy. The second practice-changing trial was at CheckMate 901. This was only in cisplatin-eligible patients, so selection based on cisplatin eligibility, GemCis with concurrent nivolumab and concurrently and continuation nivolumab as maintenance up to 2 years in the absence of interim progression or unacceptable toxicity. And that triplet, it was superior compared to GemCis alone. The hazard ratio for overall survival was 0.78, and there was also a statistical significant improvement in progression-free survival. It was interesting, Bogdana, because the median PFS was about the same. It was about 7 months with GemCis Nivo and GemCis. However, there was a tail in the curve that favored GemCis Nivo, just probably outlining and highlighting some durable responders on the tail of the curve with the addition of nivolumab. And the response rate was 57% with GemCis Nivo versus 44% with GemCis. But as you pointed out, there was a 22% complete response rate with GemCis Nivo. And the question was, who are those responders? Because the median duration of complete response, so these 1/5 of the patients have a complete response, the median duration of complete response was 37 months, about 3 years. So the question is, who are those patients? And Dr. Galsky tried to shed some light in this question and showed some data trying to characterize these complete responders. And it's interesting, if you look at the entire CheckMate 901 patient population, about 18% of patients had lymph node-only disease. And this population of lymph node-only disease seems to be enriched in patients with complete response. About half of the patients had lymph node-only disease. And I think this is not surprising because lymph node-only disease, as we know, represents a group with favorable prognosis as opposed to visceral metastasis, bone metastasis. So the data, I think, corroborate this positive prognostic value of lymph node-only subsets. Interestingly, we just very briefly touch upon the data that Matt Galsky showed. The overall response rate with GemCis Nivo in the lymph node-only metastasis was approximately 82%, and the complete response rate was 63% in lymph node-only metastasis. So it was interesting to see this, high response rate with GemCis Nivo. Of course, the question is durability of response, and the follow-up is a little bit longer in that trial. And there was maybe a small proportion of patients, very few, who had a treatment-free interval. They were able to complete treatment and then be without need for subsequent therapies, raising the questions that if we have a biomarker in the future, to Monty's point, can we select out who are those winners, kind of quote-unquote, are? You can predict the benefit. Of note, though, I think the data suggests that these patients do better overall as opposed to visceral metastasis, also with Pembro EV and even in the Javelin Bladder 100. So I don't think we have any direct comparison comparing Pembro EV to GemCis Nivo. The lymph node-only subset of patients in the EV302 also favored Pembro EV versus platinum-based chemo. So I think the whole data illustrates the positive prognostic role of lymph node-only subset versus visceral or bone mets.
And I do think a similar subset analysis for EV Pembro would be very valuable. Not that we would still be able to compare, it's not apples to apples, it's more apples to pineapples, as I've heard described. But I think it would still be a valuable analysis for that data set, knowing that you're right, we will probably see a similar response because those patients tend to do better. We're going to talk about biomarkers in kidney at length with Dr. Powell, but I don't think we're quite there, unfortunately, with bladder, but certainly that's what we're all looking forward to, figuring out how do we select the best patient treatment for the patient in front of us.
I agree completely. And going back to Monty's point, I think having these data sets give us the opportunity, number one, to discuss with patients this improved prognosis, of course, have more tools and options in our armamentarium, which is fantastic, but also give us the opportunity to design future trials for potential de-escalation of therapy. So Pembro EV, again, dramatic improvement, Could we design trials for de-escalation? Can we potentially get by with shorter duration of EV? And that's a big question for the future. And of course, in that context, we saw also another abstract by Dr. Petrilak looking at exposure to EV and response to treatment that we can touch base if you want.
Yeah, I think maybe briefly, I think that is an important consideration. Obviously, we've seen some of the earlier trials with different drugs in different spaces looking at dose escalations and dose exposures and trying to figure out, now that we have more of these agents, how is the sequencing and the exposure of it going to make a difference in their overall response? Is it a question of hitting them hard with the as high a dose as they can tolerate to at the beginning? Do we ramp up on this? I mean, what did you take away from that?
Great question, Bogdana. I would summarize it briefly for the audience. I would say the data we saw from Dr. Petrilak looked at Enfortumab Vedotin monotherapy in different trials like EV 101, 201, and 301 that were trials that looked at EV Enfortumab Vedotin as a single agent. And the take-home message was that the initial dose of 1.25 milligrams per kilogram, the standard initial dose, seems to be the one that was associated with higher response rate. So in patients who can tolerate it, with a few exceptions, this validated my practice to start with a standard dose of EV. But subsequently, the data showed that subsequent dose modifications, adjustments like holds or even dose reductions are totally fine. And if you do dose reductions, if you need to because of the toxicity, that actually is needed because toxicity and does not seem to compromise response rates and outcomes. So I think the data pretty much validates our practice that you can start with, in the most patients that you think is reasonable, with the highest dose, the standard dose, and then dose modifications, holds, delays, will happen, I would say, most commonly later. And those dose adjustments may keep the patient on treatment and do not appear to compromise responses. So that's a good thing. That it's fine. It's a reassuring thing that you can modify the dose of EV if needed. This is in EV monotherapy trials, but I think someone could extrapolate in the context of EV Pembro data.
So, Petros, just because a lot of our urology audience actually is not super familiar with using EV in their patient population, can you touch a little bit on what are the side effects that you're seeing in your patients? Obviously, you mentioned dose reduction is good, and that's important to know, but what are the side effects you're seeing that are causing you to dose reduce? What should we be warning our patients about, even as referring them to medical oncology?
Great discussion. I think this discussion may become even more relevant potentially down the road because of the perioperative trials we discussed. I think your point is important, Bogdana. Education of providers for all of us, our teams, AVPs, nurses, pharmacists, and the patient is key. So patients does not underreport, which is important. I would say peripheral neuropathy is something that is very common and something we need to pay very, very close attention because it can impact quality of life. Especially grade 2 neuropathy can impact daily activities, and obviously it's something we need to be very, very cautious about. Grade 1 neuropathy is just very mild, numbness and tingling. So neuropathy is a big one. About half of the patients on EV Pembro get neuropathy, mainly much more commonly because of EV. And it's hard to backpedal, right? Neuropathy is hard to treat. So the best way is to try to prevent it as much as possible with those adjustments. There's, of course, some treatment opportunities are effective to some degree. The other important thing is skin rash. And rash can be variable, different manifestations, different locations, different appearances, but rarely, I would say it's important to keep in mind that Stevens-Johnson syndrome could happen with EV. So extra attention to a good physical exam, complete physical exam. I always examine the patients. I think carefully we ask them to report any itching, rashes, changes, look at mucosal surface involvement, look at blisters like bullae. All those things are very, very important. And most of the rashes are mild to moderate, can be managed with topical steroids, but rarely can be severe and need some more discussions, collaboration with dermatology. Other things to keep in mind are kind of chemotherapy-like side effects like fatigue, appetite changes, taste changes, loose stool, bowel movement changes, nausea, although antiemetics are pretty effective and nausea is not usually a major issue with anti-nausea medications. Less impact on blood counts. Usually blood counts are only mildly affected, if anything. And I think the other thing is hyperglycemia. About 10% of patients, they develop a high blood sugar, and about half of them could be life-threatening. So extra attention to glucose of those patients and diabetics or non-diabetics. can happen in any scenario. So I think it's important to keep the trend of the blood sugar and not ignore it if you see an uptrend in both diabetic and non-diabetic patients.
So with your monitoring of patients, you mentioned obviously physical exam is really important for all the skin findings, talking to your patient about any neurologic changes that they're experiencing. And you mentioned hyperglycemia. Any other labs that you're ordering differently for EV?
Great question. I think the standard labs with EV, CBC, complete blood count, comprehensive metabolic panel, that includes the glucose. I always recommend the patient to follow closely with the primary care. We check hemoglobin A1C, either ourselves or with a PCP to make sure we have a very tight control of diabetes. If we look at the Enfortumab Vedotin trials, patients with uncontrolled diabetes were excluded. So that's kind of a special patient population. People may still give Enfortumab, but takes caution. And again, collaboration with primary care or endocrinologists for diabetic patients. But hyperglycemia can happen again in diabetics and non-diabetics. I think in the context of combination, Pembro plus Enfortumab, we also check, thyroid labs like TSH and 34 and cortisol in the context of Pembro because of the potential of immune-related adverse events. And I think, again, education of the patient and the team and close monitoring are key factors for optimal management and monitoring of those patients.
Thank you. I appreciate that. I think that's super comprehensive and really important to keep in mind that the more drugs that we introduce, the more side effects we all need to be aware of to make sure that patients are not having to wait too long and until the symptoms are advanced to where we have a hard time mitigating some of those side effects. So that's a very good point.
I agree with that, Bogdana, 100%. And, sometimes if someone has like diarrhea or other issues, we can always look more at electrolytes like magnesium and phosphorus as needed. So as you pointed out, I think education is key and close monitoring of the patients.
Absolutely. Well, I know we started with the advanced and the metastatic space. I want to take a minute to talk about the maintenance space. If we can talk about Javelin, looking at maintenance of Vedotin patients. I thought that was an interesting abstract because it included patients who don't have urothelial predominant histology. Obviously, a lot of our clinical trials are looking at urothelial predominant. They're not including patients with variant histologies. We're seeing patients with variant histologies. We always worry that those outcomes are different, but because there are not a lot of trials focusing on that patient population, we're forced to sort of extrapolate from other data. So I wanted to see if you had any comments on the Javelin presentation at ASCO.
Thank you much, Bogdana. It's interesting to see the data set from the Javelin Bladder 100 trial evolving over the last 4 years, and we try very hard to keep getting data out, try to squeeze this database as much as possible so we can learn from it, right? And also the colleagues learn from it. And I think it's important because there's so many questions that we can answer, right, from the Javelin Bladder 100 trial. And just very quickly for the audience, for the context, Javelin Bladder 100 was presented at ASCO, a plenary session in 2020 by Tom Powles, and we published the data at the New England Journal of Medicine in September of 2020. So in the last 4 years, I think we have seen that regimen used across different countries, and I would argue is probably the most commonly used regimen globally, especially because Pembro EV is not available currently outside US. And this was a switch maintenance trial, patients with response or stable disease to platinum-based chemo, Gemcis or Gemcarbo, if they had no progression. Selected patient population, they were randomized to Avelumab plus best supportive care versus best supportive care alone. Avelumab is a PD-L1 inhibitor, and there was a significant PFS, progression-free survival, and OS overall survival benefit with Avelumab maintenance. In this particular poster we had at ASCO last week, we look at patients with urothelial histology, but a minority histology subtype, variant histology component. So still patients had either pure urothelial or predominant urothelial, because it was a requirement for the trial to have at least predominant conventional transitional cellular urothelial component. And the take-home message was the benefit with Avelumab in this, of course, very small underpowered subset with a proportion and minority component of histology subtype. There is still benefit with Avelumab in this subset of patients. There were very few in the two subsets. I think it was 44 patients with Avelumab arm and 57 patients with best supportive care arm that has a documented minority histology component. And in this subset, we show the same data with the whole population, with Avelumab prolonging overall survival and progression-free survival in those patients with mixed urothelial carcinoma with a minority histology subtype. So the presence of this histology subtype in this minority component should not deter the use of avelumab maintenance in patients who already have achieved a response to stable disease with platinum-based chemotherapy.
Let me ask you how you think this compares to using adjuvant nivolumab, or if you think that this is data enough to potentially stratify some patients to receive avelumab versus nivolumab. Is this convincing enough to make that practice change, or is this just a comment on the data we have and you are still selecting differently?
It's a great question. I think, Bogdana, it's a different therapy setting to your point. So adjuvant nivolumab, as you pointed out, applies to patients who had radical cystectomy. If they meet the criteria to CheckMate 274 trial, they may be offered adjuvant nivo, and we have seen data with disease-free survival benefit. And we saw some data at EAU. In interim analysis, there seems to be a trend for overall survival benefit with adjuvant nivo versus placebo in that trial, CheckMate 274. I think to your point, it's a different setting. So I think it depends on where we are in terms of treatment landscape. If you have a patient in metastatic disease and you achieved a response to stable disease with chemotherapy, I think avelumab maintenance is the way to go. If you are in the adjuvant scenario after radical surgery, I would go with nivolumab just based on the trial designs. I think your question is a great one. What do we do with patients with histology subtypes? That's a major challenge overall, especially if it's a predominant histology subtype, like a variant histology more than 50% or pure. I think we need data in that setting, and I can share with you.
You can't use these trials for that one, unfortunately.
Exactly. It's hard to extrapolate, and this of course becomes a discussion with the patient. I can share with you, Bogdana and Monty, we're actually doing 2 neoadjuvant trials in predominant or pure histology subtypes, so stay tuned in the future. Different setting, of course, neoadjuvant, but we'll try to add some data in this particular patient population.
Well, if you want to mention that for a second, just for our audience who may have patients they'd want to send over to the University of Washington, you can take a minute and tell us what you're looking to find.
Absolutely, very quickly. So we do 2 trials and working with our excellent fellows in that effort. The first one actually is just finished accrual, which is exciting, and hopefully will show the data in the future in cisplatin-eligible patients with histology subtype like predominant or pure non-urothelial. Just to get data in that population, we use dose-dense MVAC with growth factor, the classical neoadjuvant chemo, plus Pembro. And we try to look at the combination in these patients and see what we get in this unique patient population with predominant or pure subtypes. And hopefully we'll show the data in the future with dose-dense MVAC and Pembro in this population. Again, this is just a clinical trial context because dose-dense MVAC and Pembro is not used outside of clinical trial. And the second trial that's ongoing, and we definitely love to have opportunity to offer this trial to our patients. It's still early on, so we welcome, of course, referrals. It's a trial for cisplatin-ineligible patients who cannot get cisplatin or patients who refuse cisplatin despite adequate counseling. And we use sacituzumab govitecan neoadjuvant before radical cystectomy in patients with histology subtypes. And that trial allows even for squamous and glandular differentiation, has to be predominant, but all the other subtypes, we allow any component of variant histology subtype, and we use neoadjuvant sacituzumab before radical cystectomy. And we base this trial on a published study we did looking at TROP2 expression in histology subtypes, and we saw TROP2 expression across some subtypes with the exception of neuroendocrine, so we exclude neuroendocrine in our neoadjuvant trial.
I swear I did not plan this as a segue to talking about sacituzumab in SURO-1 and Tropics, but I couldn't have gone better. So I think that's super exciting because I think that the trope expression is really interesting, and it ties us in perfectly to talking about the same drug. We're talking about sacituzumab, but 2 very different flavors of presentations. We saw a really exciting positive presentation, and we saw an incredibly important press release talking about a way that a new drug that everyone's really excited about did not meet expectations for patients and providers. So let's talk about the good stuff first. Let's talk about SURO-1. Do you want to give us a little bit of introduction on what SURO-1 was like?
Absolutely. I think there are some common themes and lessons learned, Bogdana, from these 2, let's say, educational opportunities at ASCO. So
educational opportunities is better than flavors.
Yeah, no, I think you're right. It's interesting to see the data, very interesting data in my opinion. So Neoadjuvant sacituzumab, in addition to our trial, Dr. Necchi's group in Milan, Italy, is doing 2 studies with neoadjuvant sacituzumab govitecan. This is an antibody-drug conjugate against TROP2, and that drug was tested in the SURE, SURE-01 trial as monotherapy, and in combination with Pembro in SURE-02 trial. Dr. Scigliola, who is a great mentee from Dr. Necchi there in Milan, did a great job presenting data from the SURE-01 trial. This trial took sacituzumab govitecan alone, and this drug is given on days 1 and day 8 of a 3-week cycle. They gave 4 cycles before radical cystectomy in those patients as a neoadjuvant approach. And it's interesting because when the trial was designed, the dose initially was 10 milligrams per kilogram for sacituzumab, the standard dose that is FDA approved for metastatic disease, and the use of growth factor was not mandated. I'll come back to that in a second, but I think that's a key point about the growth factor use. So they saw some early neutropenic events in that study, and obviously you have a curative intent scenario. You want to optimize the considerations for safety, and because of those neutropenic events, Dr. Necchi and colleagues, they amended the protocol. They actually introduced growth factor as primary prophylaxis. So in patients who start sacituzumab, they gave growth factor up front in the first cycle, for primary prophylaxis. And they also lowered the dose of sacituzumab from 10 mg per kg to 7.5 mg per kg. And they also excluded patients who had at least 3 risk factors for febrile neutropenia based on the ASCO guidelines. And based on these 3 interventions, they were able to continue the trial. The trial became feasible, and they completed, the further accrual that they had. They presented data in 21 patients, and they showed data about toxicity. I think it's very interesting because in terms of efficacy, I think 18 out of 21 patients completed all 4 cycles of neoadjuvant sacituzumab, and they went to radical cystectomy. And you see that the pathologic complete response rate, I think, was up to 48%. It was, I think, 10 out of 21 patients. So very, very impressive with sacituzumab govitecan alone. So the drug is definitely very active. And there were also a few patients who did not get cystectomy. I think there were 7 patients who refused to undergo radical cystectomy. And the 6 out of 7 had clinical complete response based on the criteria we used to define that. So the bottom line, I think, is, and they did a lot of biomarker analysis looking at ctDNA and other biomarkers, which I think very, very interesting. ctDNA is a very promising biomarker, not ready for prime time, in my opinion, in this setting, but definitely promising. And I think that the take home is sacituzumab govitecan is a very active drug. The pathological complete response rate is really high. I think is not ready for sure for prime time. The toxicity events, of course, are of note. And I think the take-home point, and I will go to the press release in a second, is if you use sacituzumab, you have to use growth factor upfront to try to mitigate the risk of febrile neutropenia. Is critical, in my opinion, to mandate that use. And that brings us to the press release, the TROPiCS-04 trial, metastatic disease, a comparison of sacituzumab govitecan, antibody drug conjugate against TROP2 versus taxane or vinfluin in Europe. And this trial was a phase 3. It tried to confirm the data from the phase 2 trial, single-arm sacituzumab, after platinum-based chemotherapy and after checkpoint inhibitor. And many patients may have received prior Enfortumab. It was allowed.
Very highly pretreated population, absolutely.
Excellent point, Bogdana. Very highly pretreated population, heavily pretreated patients. And in that population, we were expecting the data from the phase 3. We still have to see the data. We have not seen them yet. Hopefully, we'll see them in the near future. And in that press release, there was mentioning that there was no significant improvement of overall survival with SACI versus taxane or vinfluin. So it did not meet the primary endpoint. However, there was mentioning about some neutropenic events in that press release, which I think reinforces the point we just made. I think if we use SACI, we have to use growth factor upfront as primary prophylaxis, especially in patient population with bladder cancer. These patients meet criteria for ASCO guidelines. And in my personal opinion, this makes a huge difference outside clinical trials. I have seen much less neutropenic events, significant reduction with the growth factor, much less issues with neutropenia fever, ED visits, hospitalizations, all those events for the vast majority could be prevented. And of course, with optimal management of diarrhea and close monitoring of these patients, we see great results of trials. So I think it's important to see the data and see how much this growth factor use may or not have played a role in the press release that we saw from TROPiCS-04.
And just to put a fine point on this, that when we're talking about the neutropenic events, there was just a higher number of deaths in the sacituzumab, are part of the Tropics press release. So without the use of growth factor, like you're saying, this drug not only didn't meet overall survival, but there was demonstrated harm and increased number of deaths in patients that were related to the treatment, as far as we can tell from the press release. I know we haven't analyzed the data yet, but it really does put a great point on the SURO-1 trials and making these adjustments to the trial protocols and these amendments when we're starting to see these patterns to protect our patients and to benefit them from when we're seeing these adverse events add up. I think this was a fantastic amendment, and I'm very glad to see that the outcomes are much more promising with this treatment pattern.
I agree, and I think, the message out there is, if you think about dose-dense MVAC, you have to give growth factor support, and I think, in my opinion, that's similar to sacituzumab. I'm very, very eager to see the data from Tropics-04, and hopefully that will be presented in the near future for the community to review and of course, comment further as we have granularity in the data presentation.
And just one more time, highlight that in the sacituzumab trial in SURO-1 and I think SURO-2, there's a high number of patients with variant histologies. I think that almost half the patients had variant histology components, which hopefully will add to the amount of data we have for those patients, knowing that we're seeing them in clinic and we don't often have data directed for those histology subtypes.
Yeah, it's so important, Bogdana, as you said, generate data sets in patients with histology subtypes. So I discussed with Dr. Neki and Dr. Siliola, and I think between these two trials, SURO-01, SURO-02, and our trial at the University of Western Ferhat, we'll have a good data set of 3 neoadjuvant sacituzumab trials, and I think we can definitely learn from it, and we're going to do a lot of biomarker work as well, using tissue, blood, and urine of those patients. And even in our trial at UW, we use growth factor as primary prophylaxis, to your point.
So just before we jump into kidney, I wanted to say, you said Signatera is not ready for prime time. What else are you excited about in the biomarker space in bladder? Anything catch your attention in the earlier work, something that may not be ready for prime time yet, but maybe we'll do a podcast about it in the future?
I think to your point, Bogdana, Signatera is definitely the assay with the most data in the localized muscle-invasive bladder cancer. I think it's really exciting to see different trials confirming and validating the prognostic role. So I think I am almost convinced that it's extremely prognostic. ctDNA positivity correlates with higher chance of recurrence or the survival. ctDNA negativity correlates with less chance of recurrence, longer survival. That's great. And I want to commend, of course, all the investigators for doing the studies. We published one of the papers from IMvigor010 trial in Nature a couple of years ago. We had a follow-up paper a few months ago looking at the role of ctDNA based on that assay in the IMvigor010 trial with adjuvant atezo versus observation. The hypothesis that was generated in the Nature paper that we published was that the ctDNA based on the Signatera assay seems to be prognostic, but might be predictive. And I think that predictive question needs to be answered. That's what I'm waiting for. That's why I'm waiting for these ongoing trials in IMvigor011, the Tombola trial in Denmark, and the Modern trial by Matt Galsky in the US from Alliance. Those 3 trials will give us more data about the potential predictive value and clinical utility of ctDNA to inform adjuvant treatment decision-making. I think we're getting there. I am optimistic about the future. I think ctDNA will play a major role down the road, and I think with those trials and other trials, we're going to get there. Other biomarkers, there's so much work being done. It's really exciting to see the field. It's just so hard to validate the biomarker and demonstrate clinical utility. Meaning, if you use the biomarker, you are going to impact the outcome of the patient. I think we're getting much better in showing what we show clinical validity or biological relevance, that you can see prognostic difference between groups. But the highest bar is, can you incorporate the biomarker XYZ and make a huge impact on patient outcomes? I think we're getting there. ctDNA is leading the field, and I think we're getting some other biomarkers, tissue and blood-based, in a significant number of trials. But I think it will be ideal if we try to use similar assays across trials so we can have a higher chance to validate a particular biomarker or a composite biomarker.
Well, I'm going to take this opportunity to actually transition into kidney just while we're on the topic of biomarkers and ask you, Dr. Powell, are we closer in kidney than we are in bladder?
Well, I have to tell you, I wouldn't have said no prior to this meeting. I do think we made a huge leap forward with the KIM-1 data that was presented at ASCO 24.
So you're talking about the biomarker for atezolizumab.
Yeah, that's right. That's right. And I can expand on that a little bit. So this is based on a study that I led, Emotion 010, which was a randomized phase 3 study comparing atezolizumab to placebo in the adjuvant setting. And I think many of our listeners are familiar with the approval of Pembrolizumab as adjuvant therapy for kidney cancer.
First one to show overall survival.
Yeah, absolutely. And Emotion 010, unfortunately, was very, very different. We published the data in The Lancet a couple years ago, and it was just dead negative. Didn't really show any advantage when it comes to disease-free survival or overall survival. So I really applaud my colleagues at Genentech who still let us proceed forward with some really rich biomarker analyses. And we did several different approaches, some of which we haven't yet reported. But the one thing that really stood out was a proteomics analysis. And if you look at the volcano plot that we showed at ASCO 24 this year, it was just beautifully presented by Laurence Albiges from Gustave Roussy. One thing that really sort of stands out is amongst multiple proteins that we looked at, KIM-1 is really the only thing that showed differential benefit out of, I would say, hundreds that were screened. And that was in a training set of 73 patients. Then we moved on to looking at KIM-1 across the entirety of the Emotion 010 population. And, the single protein really seemed to very effectively distinguish both disease-free survival benefit with atezolizumab as well as overall survival advantage. And I think that moving forward, we've probably got to look at KIM-1 as both a way to perhaps escalate and de-escalate therapy in the adjuvant setting.
So let me ask you an uneducated question on my end. So you obviously were able to look at KIM-1 in the atezo subset population. Is this an analysis that could be run in the other adjuvant therapies that showed benefit or did not show benefit? Obviously, we know several that have been tried in this space, Pembro being the one that is more frequently used. But is this an analysis, is this data that's available to be run for the other adjuvant therapies? Or do you think that's unique to the atezo in motion data that you have?
Yeah, fortunately, there's some evidence mounting to suggest that it can be applied more widely. I give a lot of credit to first Rupal Bhatt, who was an investigator at Beth Israel. She has since moved to industry, but the legacy of KIM-1 is now carried by Vincent Zhu, who's a terrific young investigator from Dana-Farber. He's one of Tony Choueiri's mentees. I'm sure everybody on the podcast might have heard of Tony Choueiri. But Vincent's really working hard to advance the story of KIM-1 and did so initially in the context of first the ASSURE trial. We took data from a trial that was done by the ECOG cooperative group led by Naomi Haas. This study randomized patients to sunitinib or sorafenib or placebo in the adjuvant setting. And just like my study, Emotion 010, dead negative. But what's really interesting is that KIM-1 seemed to have a prognostic role, did not seem to have a predictive role in that context. And so when you move on to looking at it in the adjuvant immunotherapy studies, Vincent Zhu took the reins on looking at it in Checkmate 914. So Checkmate 914 was just like my trial of atezolizumab, a dead negative study looking at nivolumab and ipilimumab and nivolumab in the adjuvant setting. He presented this data in the context of actually, I would say, a little-known poster that was presented at AACR 2024. It didn't get a ton of attention. Since then, I think it's been amplified a lot on Twitter. But this particular poster really demonstrated very, very nicely that there seems to be, again, a predictive role of KIM-1 in this population. So I think that KIM-1 is really going to sort of pan out as a predictive marker above and beyond just atezolizumab and nivolumab and ipilimumab as has been shown so far. I think it's actually going to bear out as being good biomarker, predictive biomarker in the context of all adjuvant immunotherapy, if I had to guess.
So I think KIM-1 sounds fantastic, and that's really interesting and exciting finally to have something prognostic in this space in the near future. I think it'll make such a difference for our patients. I want to ask your thoughts on looking, now that we're looking at separating out kidney cancer trials and looking for patterns, looking at angiogenic or immunogenic clusters from the CLEAR and the KEYNOTE trials.
Yeah, it's an interesting topic, and it's something that I'm so thankful to our colleagues in pharma for doing with us. Because honestly, I think the initial imperative is just to report out the clinical data, but they've taken a step further and done this really sort of challenging and comprehensive look at whatever tissue they had to see if there's any predictive tissue genomics. This year at ASCO, we saw data for two important trials, as you highlighted, Keynote 426, which was a randomized phase 3 study comparing axitinib and pembrolizumab against sunitinib therapy, and the CLEAR trial, lenvatinib and pembrolizumab versus sunitinib, same phase 3 design at the meeting. It was interesting, and if I can give you sort of the top line evidence that was presented, it seems as though in the CLEAR study, we didn't really identify a particular signature that was associated with benefit of lenvatinib and pembrolizumab. They looked at all the signatures that had developed across multiple studies, including, as you'd mentioned, the angiogenic and T effector profile signatures. With axitinib and pembrolizumab, on the other hand, it did seem as though if you had the T effector cell signature, you seemed to do better with axi-pembro. But, frankly speaking, I think that patients with axi-pembro did better across the board. So I don't know if it rises to really the level that we would be using these biomarkers in clinic, but interesting data nonetheless.
So if I could just ask you to take a step back from the biomarker data and from the axi-pembro or the len-pembro subsets, when you are seeing these patients, are you looking at them any differently in light of any of the recent trials presented? What are your first-line treatments that you're using? What are you thinking of distinguishing patients on? Or maybe nothing yet?
Yeah, no, it's a fantastic question. I mean, I think that I tend to be fairly dogmatic. Usually if I'm really trying to maximize response rate, I'll go with the VEGF TKI IO population, and that's usually the imperative for most patients. And amongst the various VEGF TKI regimens with IO, I tend to use cabozantinib with nivolumab. We had a nice discussion earlier today about quality of life in the context of EV Pembro, and I think that's the one TKI IO regimen that seems to be improving quality of life. And I really think it hinges on the fact that with Cabo-Nivo, we're using sort of a slightly lower dose of Cabo than we're used to in the second and third line setting. However, I do think there's very appropriate candidates for Nivo-Ipi up front as well. If you have a patient who, and this is really where I think our interplay as surgeon and medical oncologist come in. If we have a patient who needs to go to the OR right away, if there's some absolute indication for surgery, I love the idea of offering them dual checkpoint inhibitors so that you can take them to the OR, Dr. Schmidt, and do what you need to do, and then I can continue my systemic therapy in parallel.
Perfect. I just think it's really nice to have that context to figure out what people are thinking, because now we actually have multiple options, and it's a wonderful place to be in for our patients and providers alone, but it also makes it more difficult because you carry that burden of did you make the right choice right away, and not wanting to take your patient across multiple lines of treatment, knowing that the more lines they go through, obviously, the worse the response to each subsequent line will be, and trying to figure out how do you make that better first choice at the time of seeing the patient.
Well said. Absolutely. It's really hard at this point in time to adjudicate treatment based on genomics. I'm hopeful that one day we'll get there. But right now, I think it's really based on clinical intuition, the characteristics of the patient sitting in front of you, and a long, hearty discussion around side effects.
So since we're talking about the patient sitting in front of you, do you want to talk a little bit about looking at very good risk RCC, that kind of category, and how you're treating those patients differently, or maybe subtypes like chromophobe?
Yeah, absolutely. There was some informative data at ASCO 24 around this very good risk population. And, I would say it seems somewhat intuitive, right? The very good risk, definition that they applied at the meeting this year included those patients that had a duration from the time of diagnosis to the time of systemic therapy of more than 3 years. And I would say that, that's the sort of patient that you and I look at and say, hey, this patient has a very different sort of protoplasm. I think this person's going to do well. And it seemed
for
as
me,
though,
that patient is the patient I just think of surgery as the treatment. If it takes them that long, if there's something that we can cut out, that's the patient we're often looking at and saying, well, do we need a systemic treatment, or is this something we can kind of keep whack-a-moling, so to speak?
That's such an important point. And, we're starting to use oligometastatic therapy more and more in renal cell, whether it's surgery or radiation treatment. So I'm glad you brought that up. And in that Venn diagram, there probably is, a certain number of individuals who are very good risk that could benefit from just definitive therapy alone. You're absolutely right. If I were to give the investigators the benefit of the doubt and, say that, okay, they've considered that, they do need systemic treatment, the data did seem to point towards the combination of TKI with IO being slightly better. This actually got really fiery at the meeting, Dr. Schmidt. There was a Q&A session afterwards, and it was a poor young investigator that was presenting the data for this very good risk population. And he sort of got skewered after making the statement that we should be using TKI IO in this population. But I do think that maybe that was a little bit too bold. I can see the point that folks are making. This is a small subset and already just 20% of patients that have good risk disease. So it's hard to make any definitive claims, but at least there's a hint here that maybe TKI plus IO is better. It's still the investigator's prerogative, though, regarding what to use.
Absolutely. I just think it's great to have options and conversations. I think fiery is good. I think it means we finally have more to offer our patients. If we're all in agreement, that means we only have something that doesn't work.
Yeah, totally. I couldn't agree with you more.
Works extremely well, which would be great.
And I'm glad that you I think this fiery debate also applies to how we treat non-clear cell kidney cancer. And you mentioned chromophobe just a moment ago. There's some really interesting data from a multi-institutional collaborative that looked at chromophobe RCC. And this was presented by a young investigator from Sloan Kettering who really gave a terrific talk. And it looked at the strategy for metastatic chromophobe, comparing TKI versus TKI plus IO. And in general, it seemed as though TKI IO is better. But again, I do, exert some caution here. These are small data sets, but when you think about chromophobe and how exquisitely rare a population is, it may be some of the best data that we have to go by. So, I do think that the series of 99 patients, while it, isn't anything that we can hang our hat on as being definitive, does offer a really nice hint as towards what might be better.
I think it's exciting. Certainly being able to treat our patients according to the disease profile they have, whether that has to do with biomarkers or has to do with disease subtype or anything else we can hang our hat on, is going to lead to better improvements, whether it's in treatments, maybe providing treatment-free intervals, maybe quality of life, whatever it is that we'll be able to parse out that'll still benefit our patients. I want to finish off our kidney talk about DFF332, what you described and presented on the HIF2 inhibitor for RCC. I want to finish with something exciting. So could you talk us through that a little bit? Because I think this is one of the more interesting and exciting things presented.
Oh, thanks a lot. It's very kind of you. And I think that this has the potential to be exciting. So this was a dose escalation study looking at a novel HIF2 inhibitor called DFF332. Mechanistically, it works in a fashion that's similar to belzutifan. Belzutifan blocks HIF2 alpha, and it actually blocks a domain in the molecule called PAS-B. And DFF332 does something quite similar to that. I will say that if I can describe the study as this fairly, I call it incomplete in the sense that we actually looked at multiple dose levels of DFF332. We stopped at a dose of 150 milligrams daily. And I think we probably could have gone further because we really didn't see any toxicity with it. The most substantial toxicities that we saw were an occasional grade 4 event of dyspnea. And beyond that, the agent was very, very well tolerated. We didn't see any dose-limiting toxicities in the study that would have prompted us to cap at a certain dose. We didn't see a lot of anemia. We didn't see a lot of hypoxia, which are two of the classic side effects of belzutifan, for instance. And it kind of gives me the signal that we could have gone further with the dose titration. And so one of the things that came up in the discussion is that the agent is no longer going to be developed by Novartis. And I'm really hoping if there's a listener out there with deep pockets who wants to take this on, that they take
I'm sure they're all listening to BackTable, but
awesome,
please,
awesome.
All of our very, very wealthy patrons of urologic oncology, get in touch.
There you go. There you go. I really do think there's an opportunity here to develop this drug with its toxicity profile, with the fact that we were seeing some activity with it at these initial dose levels. I think that if we were to sort of raise that dose further, get to something that's well tolerated still in kidney cancer patients, there's room for it. Belzutifan is an amazing drug, and I think that it's going to find application in a number of settings, but the development plan for belzutifan, I think, is pretty well established. We have our big trials of belzutifan in the adjuvant setting, front line, second line. So for all the other exciting drugs that are coming out there in renal cell, we might want to potentially have another HIF2 partner. And I think the DFF332, the Arcus compound, perhaps the compound from Nikang, all of these could potentially represent good partners for other agents in the space.
And is that sort of how you envision it, not as a single agent, but potentially as a combination, kind of like belzutifan with cabozantinib?
Yeah, absolutely. So I do think you're spot on there, Dr. Schmidt. So I don't think that we're probably going to see a landscape where we can edge out the competition with just DFF332 alone. Maybe it'll find a place as belzutifan has right now in that salvage setting. But I do think that the place for a lot of these HIF2 inhibitors is earlier, maybe front line, maybe second line, maybe even adjuvant. And certainly we're going to have a lot of new and exciting kidney cancer drugs coming through in the coming years. And if belzutifan isn't available for whatever reason as a partner, maybe that could be DFF332. So again, deep-pocketed listeners, give me a phone call. We'll talk.
Well, on that note, I think we can wrap up the very exciting ASCO 2024. So I just want to thank you both so much. I know this was an exciting ASCO. I'm sure our audience learned a ton from you both. I know I did. Dr. Grivas, Dr. Powell, thank you so much for joining us and talking about ASCO 24.
Thank you so much, Bogdana. Such a great opportunity. It's really, rejuvenating and refreshing to see the progress made in the field in both kidney cancer, bladder cancer, across GU cancer and across oncology. So looking forward to more discussions together with you. And we look forward to the ESMO meeting in Barcelona in the middle of September. So a lot of data will be happening there, presented there. So looking forward for more. And thank you for your time and invitation today.
How could I say it better than Petros? It's been a pleasure to be here. Lots of really great topics and really cool advances in the field this year at ASCO.
Thank you so much. This was fantastic.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.